Hello, my name is Tiago Reis. I'm a nephrologist from Brazil, and recently I've been publishing a lot about COVID because now I'm working as a fellow research in Vicenza, Italy, with Professor Claudio Ronco. I was invited to present this lecture because one friend, Sid, was talking to Peter about this very article here I'm showing you. And he said to Peter that we were friends. So for me, it's a pleasure to be amongst of you in this journal club meeting. These are my conflict of interest. And this is Professor Claudio Ronco. This is the team of fellows. Vicenza is in the north of Italy, and this is where I work. This is SanBartolo Hospital, where in this first floor here is the ICU, and we have also the research center in here. Well, Prof. Claudio Ronco is an outstanding man, and it's easy to know why I choose to come here. So he has published more than 1,000 papers, more than 90 books so far, more than 700 lectures in international meetings. And these are the citations per year from Prof. Claudio Ronco. So you can see that last year he got almost 7,000 citations. He has a YouTube channel called Cappuccino with Claudio Ronco, where every week he records videos about studies, about his courses. I recommend you to follow his YouTube channel. So as I said, I met Sid, who now works in Abu Dhabi, because my boss in Sao Paulo and his boss in the USA, they were friends. He sent him to Brazil. We met there. And then in 2016, I went to Sunderland, where he used to work. And then in 2018, I went to Abu Dhabi for the first time. Well, these are the numbers of a kidney hospital where I used to work, where I met Sid. This is the first transplant center in number of transplants per year, almost 1,000. So this was in 2019, total of 900 transplants, 200 of living kidney donor and almost 700 from deceased donor. This was me in Abu Dhabi, 2018. I presented 3 lectures there and I had a wonderful time. Well, let's talk about COVID-19, right? So there is this sequence of virus through species like influenza, the swine influenza, and COVID-19 in the beginning, the culprit was pangolins. But after studying the genetics of the virus, we can now affirm that it came from bats in the end. The thing is that 70% of pangolins are positive for different kinds of coronavirus, and they share, one of those coronavirus share 85% of the viral genome with SARS-CoV-2. But as I said, further research proved that it came from the bats after all. Well, this is the ACE2 receptor, angiotensin converting enzyme receptor through species. And this is where the virus links to get inside the cell. And there are many theories about ACE2 pathway. I think it's important to mention this because we are amongst nephrologists, right? So this first author has a hypothesis that ACE receptor and the drugs that inhibit the enzyme ACE and ARBs might increase the risk of COVID-19 infection. Why so? Because they would upregulate ACE2, So there would be more expression of this receptor where the virus could link and get inside the cell. On the other hand, south, all these articles are from this year, of course, hypothesized that the angiotensin receptor blocker, ARB, like losartan, attenuate angiotensin 2 mediated lung injury by blocking ACE2 receptor. So these are opposite ideas. And the third hypothesis, which is also, let's say, plausible, says that if we give those patients exogenous angiotensin 2, this drug is FDA approved for patients with hypotension shock. So if we gave that angiotensin 2 to patients, there would be a competition between the virus itself and the exogenous angiotensin 2. Then there would be a downregulation of ACE2, and that would reduce the viral entry. So this represents the host cell in lungs mainly, but it's spread in kidneys, heart, gut. Anyway, the virus links with ACE2 here, and then is entering the cell. So one of the theories saying that it could be protection using the ARBs is that you would have less AT1 and angiotensin 1 harms the pneumocytes. So, you know, opposite ideas. The clinical course of COVID-19, most of the patients, you are aware, they are asymptomatic, but those with mild or moderate disease, they have mainly fever, dry cough, fatigue, sore throat, they lose their smell, their sense of taste. Well, usually their labs, they have lymphopenia, high ALT and high LST, high CK, and according to the lab diagnostic tests, in the first phase, you can isolate the PCR, and then after 7 to 10 days after the infection, you already have the production of an antibody. Usually, the patient stays about 7 days with symptoms, and then he needs to seek for medical attention. And usually after 7 days of entering in the hospital, those patients who are more prone to a bad outcome, they develop a multi-organ failure with acute respiratory distress syndrome, septic shock, acute kidney injury, myocardial injury, and the final pathway to multi-organ failure, or multiple organ dysfunction syndrome, synonyms. And there is this concept of organ crosstalk. So injuries in the kidneys or in the heart, they also affect the functionality of the other organs. This is the paper that we published 3 weeks ago, and we try to represent how COVID-19 can harm the kidney. So here is the virus. Many of the patients are asymptomatic. Many have mild symptoms, but some have a more aggressive presentation of the disease. Mainly, the virus creates a state of hypercoagulability and endothelial injury. Of course, pneumonia, acute respiratory distress syndrome, and cytokine storm or cytokine release syndrome. And I will talk in detail about that in the next slides. And also hypovolemia, because remember, that patient, he was 7 days in his home with fever, hyperexia, and usually when this patient seek medical attention, they are severely dehydrated. So all those factors, they impact in kidney function. Here is pre-renal acute kidney injury. There is also direct viral invasion to the kidneys. So in electron microscopy, viral particles were found in endothelial cells of the kidney, podocytes, mainly in the proximal tubule, but affecting directly the kidney. About hypercoagulability, we hypothesize that there is endothelial injury, production of fibrinogen, and this creates a state where you can have microthrombi, you can have embolism, which is frequent in those patients. Also, the damage made by the cytokines can cause myocardial dysfunction, and with myocardial dysfunction, you have an increase in intravenous pressure. This increased pressure is transmitted to the kidneys, and like the perfusion of the kidney is the difference between the mean arterial pressure and the intravenous pressure. This gradient is what drives renal perfusion. So if your heart's not properly working, you have an increase in the venous pressure, then your gradient would be lower and the kidney perfusion will be lower. That's important to say. There is the renal compartment syndrome, which means that the kidney capsule is not compliant. So if you have an increase in the venous pressure, the kidney cannot expand and is submitted to these high levels of pressure. This figure that we presented in the same article is more specific for nephrologists and explains how should you do extracorporeal treatment in those patients. So first, there are the indications for renal replacement therapy in these patients, which are the same as from other patients with AKI. Oliguria, hypervolemia, hyperkalemia, severe acidosis, and azotemia. And if you have also the presumed diagnosis of cytokine release syndrome, you can apply different kinds of filters. So these are the indications. Then you have the preparation. We advocate for a large catheter in the right jugular vein. That's important because the blood flow is related, and the resistance of the blood flow is inversely proportional to the size, the diameter of the catheter. So the wider is your catheter, lower is the resistance to blood flow. We advocate also for right jugular vein because those patients, almost 40% of those patients, they need to be prone in order to treat the acute respiratory distress syndrome. So if your catheter is in the femoral veins, the risk of kinking is higher, and you cannot see the entry site. You cannot see if it's properly anchored in the skin, in the patient's skin. So this would be the #1 site for catheter placement in COVID-19 patients. The prescription, we advocate for those severely ill patients to be placed on continuous renal replacement therapy because we think that the hemodynamic impact is lower and you can remove more fluids of those patients that are usually hypervolemic. We tend to use more citrate as regional anticoagulation, but you can also use heparin. The thing is that those patients, they need higher doses of heparin or citrate because they are in that hypercoagulable state. The dose of dialysis is the same as for other patients with AKI. To check then the delivery, some parameters are really specific. I won't go through all of them. And then monitoring. So you should also monitor how is your catheter every time you go to check the patient, the pressures of the circuit that your machine is pointing to you. If using citrate, you need to check if your ionized calcium in the machine and also in the patient is in the proper range. And if you're doing systemic anticoagulation with heparin, you also have your targets. So in those patients with multi-organ failure, they can develop acute respiratory distress syndrome, acute kidney injury, acute liver failure, cardiogenic shock, and vasoplastic shock. For all of those syndromes, there are treatments. So for ARDS, you have extracorporeal membrane oxygenation, but mainly mechanical ventilations. For AKI, we have CRRT, and for others, mainly vasoplastic shock, we use vasopressors. Normally, norepinephrine, vasopressin, and there is also now available angiotensin II. This recent paper from New York showed that in this cohort of about 5,000 patients hospitalized due to COVID infection, 33% developed acute kidney injury, and 5% of all those patients required renal replacement therapy. And these are patients according to their stages of acute kidney injury. Well, for those that are not nephrologists, for the medical graduates, I will briefly explain how dialysis works. So you have the blood coming into the filter and then leaving, and you have a solution called dialysate that goes entry in different direction and then leaves the system. There is no contact between the blood and the dialysate. I will show that in the next slide. So we have a double lumen catheter, 2 lines in the same catheter. The blood comes from here, and there is a pump that sucks that blood from the venous system. It goes through the filter and then return to the patient. On the other hand, the dialysate perform this pathway. So if you open a dialyzer, the name that we use to the filter, there are many fibers, the capillary fibers, because they are tiny, and they have this, they are like tubes, and the blood flows inside those tiny tubes, whereas the dialysate goes outside. So there is no direct contact between the dialysate and the blood. This is an electron microscopy of those fibers. And this is the wall of the fibers that resembles a sponge. And so there is a change for diffusion and convection. So things from the blood, they go from here to here, and things from the dialysate can come from here to here where the blood is. This represents the patient. So, and the circulatory system, this is the heart pumping 5,000 mL per minute, and of the whole volume of blood, only 20% is in the arterial system, which is a system with high pressures and low, high resistance as well, and low capacitance. On the other hand, the venous system keeps 80% of the total blood volume in the circulation and is a circuit with high capacitance and low resistance. So when we do dialysis, we are only dealing with the venous compartment. We are not dealing with the arterial compartment. So the blood, it's a closed loop circuit because the blood comes from here, goes into the machine, the filter, and then is returned to the patient. This is a figure that we published 1 week ago. It's a review showing the different pathways in which the virus can create acute kidney injury, and at the same time proposed treatments. So first is the mechanism of cytokine release syndrome due to the virus itself, but also due to ECMO, mechanical ventilation, renal replacement therapy. All those treatments, they can cause cytokine release. And we have special filters developed in the last 5 years that they have more pore density and they can remove more cytokines. They are called middle cutoff filters. Also, to remove cytokines, we have cartridges that resemble a sponge, and they can absorb cytokines. Well, the kidney can be damaged by systemic factors. So positive fluid balance, and I've explained about the renal compartment syndrome. We have endothelial damage. We have the so-called capillary leak syndrome. So it's like the third loss of fluid from intravascular to the interstitial space, causing to reducing the effective blood volume, intravascular blood volume. And the crosstalk that I've mentioned before, when you have acute kidney injury, you can at the same time have a cardiomyopathy due to also cytokines. You can have rhabdomyolysis, in which the virus is in the muscle cells, and there is a release of myoglobin, which is toxic for renal tubules. And to treat those conditions, for example, the rhabdomyolysis, you can apply this kind of membranes, and they also remove myoglobin, which has almost the same size of cytokines. This is another article that we've published in Nature Reviews in April, saying the same thing as in the previous image. So we have organ crosstalk, cardiomyopathy or viral myocarditis that creates cardiorenal syndrome type 1. And to deal with that, you can use left ventricle assisted devices and extracorporeal membrane oxygenation, arteriovenous. If you have acute respiratory distress syndrome, you have alveolar damage, you have renal medullary hypoxia, and you can treat that with ECMO. Because of mechanical ventilation, you have high peak airway pressures. You can have that. You can develop intra-abdominal hypertension, and then renal compartment syndrome. And to deal with it, you can use ECMO, extracorporeal CO2 removal, and continuous renal replacement therapy. This name, CRRT, is the proposed new nomenclature from KDIGO, but we don't like that. We prefer CRRT. And you can have rhabdomyolysis and remove myoglobin with CRRT. Systemic effects. So if you have positive fluid balance, you can also develop renal compartment syndrome. And to deal with it, you do continuous ultrafiltration and use diuretics. For endothelial damage, the capillary leak syndrome that creates renal hypoperfusion, you need vasopressors and fluid expansion. So here you need ultrafiltration, and in this case you need fluid expansion. Again, rhabdomyolysis. And for endotoxins, I will explain that further. You can develop septic acute kidney injury, and we have devices to remove endotoxins, which are particles, molecules from the wall of gram-negative bacteria that they can create shock, the response of shock. And about cytokines, we have the so-called cytokine release syndrome. and there is a direct cytokine lesion to the kidneys, and we have filters and cartridges to remove those cytokines. And rarely you have hemophagocytic syndrome, which is a prototype of cytokine release syndrome, and I won't go further in details. So this is the theory proposed by my boss, Claudio Ronco, is the theory of cytokine peaks. We published this in March. So you have first the viral infection, viral pneumonia. Sometimes you need to apply ECMO, which is the extracorporeal membrane oxygenation, and also mechanical ventilation. The pneumonia itself, caused by the virus, creates a state of cytokine release, but also the ECMO and also mechanical ventilation. And then you have the release of those pro-inflammatory cytokines. At the same time, you have the release of anti-inflammatory cytokines. And the ideal thing would be that those two phenomena would balance themselves and the patient will get cured. However, there is a sort of threshold, and if your cytokine peaks are above that, then you have an immune dysregulation state, and those anti-inflammatory cytokines can also be harmful, because after the first peak of the inflammatory cytokines, the patient can develop a state of immunoparalysis. And those patients that survive 7 to 10 days after they are admitted to the intensive care unit, they can be considered patients with immunosuppression, and usually they develop infections, opportunistic infections, because they are in this so-called state of immunoparalysis. And applying to those patients a technique called hemoperfusion or hemoadsorption, we would avoid those peaks of cytokines, because we will remove the outlier cytokines with this treatment, and the patient would not develop this hyperinflammation and at the same time this immunoparalysis. And that's the so-called cytokine storm. This would be the threshold. So the ideal situation to deal with infection would be to have first an pro-inflammatory response of cytokines and then an anti-inflammatory. After all, he would be recovered. And if you have this unbalance, this outlier cytokines, then you can have negative outcomes. So these are two examples of cartridges for hemoadsorption. They are small balls. They look like caviar for those who like to eat caviar. And this is the electron microscopy of those tiny beads. This is an experiment that we run in our lab. Oh, it's not so good as I thought. Okay. And this is amazing because only one cartridge has an area of 45,000 square meters. So it equals 9 soccer fields, whereas a dialyzer has 1.6 square meters. So one cytosorb has a surface area of 9 soccer fields. So this is in our lab. This was a solution, and we were running it into the cartridge. This is another type of therapy. So imagine here is the vascular access. The patient will be here. So the blood comes in here. There is this blood pump that pushes the blood. It goes here, and here we have a plasma filter. It's a different filter than the dialysis filter, and so almost 30% of the plasma goes in this direction, and the rest keep this path. This plasma goes through the cartridge, where it occurs the adsorption of cytokines, and then they meet here in the bubble trap. The other part of the blood goes and is dialyzed. So here is a dialyzer, a normal dialyzer, and it makes sure here in the bubble trap. So with this treatment, we can do simultaneously hemoperfusion, hemoadsorption, and hemodialysis. This is the machine that we use to do that, and this is the video showing. So I'll briefly try to explain. The blood goes in first in this direction. This is the plasma filter, and this is the plasma. It would go in this direction, pass through the adsorptive cartridge, and then pass in this pump, and would find again the blood in here. So the blood was coming in this direction. It goes from here, and then meets here with the plasma that has already passed in the cartridge. This is another technique, but not for cytokine removal. It's for endotoxin removal. So as I've explained, in the wall of gram-negative bacteria, you have the lipopolysaccharide, which is also called endotoxin. And this substance, this molecule creates vasoplagic shock. So if you have a gram-negative bacterial infection with septic shock, removing those endotoxins, you can treat your sepsis. It's the similar treatment. So the blood comes from here, passes through different kind of cartridge, and then returns to the patient. This is one of those cartridges. In order to carry out this therapy, you need to know if the amount of endotoxin is high enough that that treatment would be advisable. So this is in our lab, we are analyzing the endotoxin activity, and based on those results, we will or not carry out the treatment. So the treatment here is endotoxin absorption, not cytokine absorption. And here is that in the patient. So the blood comes from the patient, goes inside the filter, passes through here, goes into the bubble trap, and then is returned to the patient. This treatment takes 2 hours, and we perform it in 2 consecutive days. Well, but there is a thing that I will say now that might surprise you. So in this study from 2006, an antibody was being developed, and this monoclonal antibody would activate T cells. And it was administered to 6 volunteers. The name of the antibody was that, the GN. And 12 hours after the infusion, those patients that received the monoclonal antibody developed ARDS, renal failure, disseminated intravascular coagulation, severe depletion in lymphocytes and monocytes, and had high levels of D-dimer. So if I describe this picture, anyone would say, oh, this is COVID-19, because it's just the same picture, right? And in those patients, the cytokine levels were measured, and for IL-6, which is a pro-inflammatory cytokine, the peaks were around 3,000. Okay. In another study, more recent from 2014, patients with sepsis were analyzed, and they had the same amount of cytokines in the range of 4,000, 5,000, 44,000, sorry, 50,000, I mean, high levels of IL-6. Well, in COVID-19 patients, we're not seeing so high levels. So this is for interleukin-6, for patients that died, and for others that were discharged. Those who died had higher levels, but they were here 12, in the mean 12, 13. In this another study from Zoo in Lancet, this represents the levels of patients that died, that didn't die, sorry, and these are the patients that died. So we have higher levels of IL-6, okay, but not so high levels, 26. And in another study, the levels of IL-6 in patients that were admitted to the ICU versus those who were kept on the ward, they were similar. There was no statistically difference between the levels of IL-6 in those two groups. So, does it make sense if you don't have a cytokine storm, if you are in the middle of Abu Dhabi desert to perform treatments to remove cytokines? It makes sense to bring an umbrella to the desert. So that we don't know yet, and we can't say that the hyperinflammatory state is only driven by interleukin-6. We believe other cytokines create this state of hyperinflammation, and as in those patients here from this study from 2006, they have the same picture of those patients severely ill with COVID-19. So it's likely that we have the same background for COVID-19 patients and from these other patients outlined here. Well, this is my social media devoted to nephrology. I am on LinkedIn. I am as Tiago Reis. I am on Instagram as The Nephrologist. And I have a YouTube channel, my name, Tiago Reis. All of them devoted to nephrology. So it was a pleasure talking to you. And feel free to contact me in my email, which is displayed here. Thank you.